In rural hospitals, critical access hospitals are in crisis in America, and they're closing down at a shocking rate. When a hospital closes, health outcomes for a substantial radius are measurably worsened by that. When we can keep one or two more patients in their average daily census there present, and the income from that care, the bed days, the pharmacy, the lab, the imaging stays in that community, then everybody in that community benefits.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm Dr. Cyrus Atkin, here with my illustrious co-host, Dr. Nick Mark.
Cyrus, thanks for the intro. Yeah, it's really great to be here to discuss a topic that isn't talked about enough in the world of critical care education. I'm talking about tele-critical care medicine.
Yeah, I'm incredibly excited to be able to explore this topic today. It's one that I have some experience with, having practiced medicine overseas in a resource-limited environment for a little while, but I am by no means an expert.
Yeah, I'm not an expert either. I mean, I've actually done this as part of my job for a few years and did a fair amount of this during the pandemic, helping out like in New York when they were hit. And despite that, I feel like I've got a ton to learn. So as we often do here at Critical Care Time, when we find a topic that we think others could help us talk about, we call for reinforcements.
That's right, and like Lando's fleet of fighters arriving in The Rise of Skywalker, the Rohirrim arriving to fight alongside Aragorn and friends at the Battle of Helm's Deep, or perhaps the Knights of the Vale who arrived just in the nick of time to save Jon Snow from certain defeat, we are fortunate to have some heavy hitters fighting alongside us as we explore telecritical care medicine.
I don't think I can get behind J.J. Abrams' Star Wars as a reference, but I definitely co-sign on the Rohirrim and Knights of the Vale. I guess to play with your analogy there, we also should thank one of our team members, Dr. Blegev, who in that analogy is either Gandalf or Sansa, I guess, for introducing us to our guests. Maybe we should just get to introducing them.
Perfect.
So Dr. Bill Beninati is a critical care and pulmonary physician who's serving as the chief medical officer for Intermountain Health's virtual hospital, which consists of air medical transport, telehealth, a clinical command center, and outreach. He's a retired U.S. Air Force colonel, and after a career that included deployment and formal leadership, he applied many of those skills in the hospital to develop this system.
And with Bill today is Dr. David Guidry. He's a pulmonary and critical care physician at Intermountain. He is the medical director for acute and adult telehealth subspecialties. His career interests lie in leadership development and mentoring, as well as process improvement to provide highly reliable care.
We've got a great show lined up. Really excited to have these two experts on as we delve into the important topic of telecritical care. All right, so before we get into the weeds, maybe you two would like to introduce yourselves and kind of set the stage for our discussion. Maybe tell us what got you interested in telemedicine. Bill, do you want to go first?
Sure. So when I was in the military, I spent some time stationed in Hawaii, and at that time, our last bed on ICU rounds was a telecritical care bed to Guam. And so I started as part of a development project there, working in that mode a little bit. And it was kind of nice because as a transport guy, sometimes if a patient needed to be transported, I could hand off my beeper, get on a C-17, fly out to Guam, and now bring my patient back and take the beeper again. And so that plus my experience, I guess I would say, in the conflicts involving Iraq and Afghanistan, where we functioned as a single medical staff from the farthest outpost all the way back through the continental United States, we linked together our practice and our mindset and in a way that was very effective in terms of improving care. So fast forward to now my time at Intermountain, when I'm essentially the system level ICU medical director for a few years. One of my projects was to launch telecritical care as a way of connecting our very rural, remote hospitals and our transport system all the way back through our tertiary centers and our big academic medical center.
And David, how about yourself? How did you get into this?
So mine was a little bit more serendipitous than that. I, at an early point in my career, was looking to get back to the mountains, and very timely, Bill called me one day and asked if I wanted to come back and help start the telecritical care team. And it was a perfect opportunity. I will say, with full disclosure, that I wasn't super excited about providing telemedicine initially because my experiences previously with it had not been amazing. But we have done, I'll laud our team here. We've done such an amazing job developing relationships with our colleagues at the bedside across our system and throughout the system that it's been as rewarding a part of my job as working at the bedside now. So I really, really appreciate my time doing tele.
And I really want to get into the why on that in a second, because I think understanding the difference between a model where it's really enjoyable and the other model is really important.
Yeah. Yeah, I think we're going to touch on that and a lot more during this episode. So I think, now that we've gotten some of those introductions out of the way, perhaps we can start by just asking that fundamental question of what is telecritical care? And then I also wanted to quickly mention that you guys specifically endorse that term telecritical care as opposed to things like tele-ICU or EICU. So maybe, Bill, perhaps you can let us know what is telecritical care? And then David, you can pick back up with that second question I asked.
Yeah. So telecritical care, in general terms, is a model for providing critical care services to patients who are remote from the location of the caregiver team, the interdisciplinary caregiver team. So that's in simple form what it is.
Great.
Yeah. And, to answer the second question, Cyrus, I think the terms you're talking about when we think about telecritical care versus tele-ICU versus EICU, for one thing, EICU is a trademarked term and it's proprietary for Philips. So that's not something we should apply widely to the discipline as a whole. And we prefer, and really the Society of Critical Care Medicine prefers telecritical care because it really projects providing critical care where it's needed, whether that's in an ICU, which is the majority of what we do, whether that is in an emergency room, helping to triage patients or optimize patients prior to transport, or responding to code blues on a medical ward, even to medical control for medical transport, whether that's helping to treat patients while they're in the air or in an ambulance or even on the scene.
I love that distinction, by the way, because I think one of the things that we really thought was important in making this show was, that it's about critical care wherever that's provided. The ICU is a place. Critical care is, life saving interventions that are performed by experts. And to Bill's point at the beginning, that could be performed 4,000 miles away from where you are. It could be performed on a C-17. It doesn't have to be a physical ICU. So I love that the nomenclature reflects that. Maybe getting into the nuts and bolts a little bit. So how did telecritical care groups operate? Like, what does a program look like organizationally and technically?
So there are a range of different organizational models for this. In general, the idea is that you have a team of providers, so physicians and APPs, teaming with clinical nurses and then potentially other disciplines. Pharmacy is a very popular one, respiratory therapy, potentially others, consulting services that function either out of a shared clinical command center, which is how we started out, or potentially you can build a team remotely. And we've had to, the necessity of our growth means that we have some people who have never set foot in Utah who connect with us electronically. And so that's where the services are being provided. And of course, you can go anywhere that your electrons go. Ideally, you'd want to have two-way audio video at the patient's bedside. And that is important, I would have to say, just the observation, right? If we think about how we learned, to do a clinical assessment, the importance of history on a physical exam, the importance of just observation. Well, this drives us to do that. And so I would think that our history taking skills and our observation skills maybe grow and improve because we lose the other senses operating through the camera. So that's basically how it's structured. But you have to the demands of life mean there's some flexibility. Sometimes your audio drops. Sometimes you're taking a medical control call to an aircraft where you can get video. Sometimes you're taking a control call to an aircraft where not only is there no video, the audio is going through a satellite phone, or the audio is poor quality because of helicopter sounds, that kind of thing. So, for every general description, there are a lot of exceptions. And I think it's important for the people practicing this environment to be able to roll with those exceptions.
That makes sense. And David, I don't know if you could touch on kind of some of the different care models. I know Bill kind of alluded to some of the ways you can sort of set up your structure with that sort of. I think you guys in your book chapter refer to it as the hub and spoke model. I know you can also have a decentralized setup where you have different agents in different places. But how about those specific care models?
Yeah, so care models, I mean, it can, like, as you said, the structure is one way to think about it. And then how you're providing the care, whether you're providing 24/7 continuous care, which is what we do, where our whole team is always available and ready to go. That's including nurses and pharmacists, APPs and RTs. Um, whether it is just on a episodic or consultative basis where we're intermittently available, or if we're just responsive and being involved in patient care when we're called and asked to. Like I said, our model is more of a 24/7 continuous. We provide proactive care from what at one point, as Bill said, was a centralized location. Part of our team is still in the centralized location, but we have other nodes. The original models were called hub and spokes, but now we have hub, nodes, and spokes. Um, with the nodes being, at least at Intermountain, we have numerous command centers. We have our main command center in the Salt Lake Valley and a couple of others across the state. But then providers will frequently work from home, and whether home is somewhere in Salt Lake or uh, across the country, that still seems to work out very well. And what we provide is a 24/7 continuous coverage model where we proactively round on every single patient in every single ICU we cover and try to provide an initial consultative review within the first hour of arrival to help ensure that patients are receiving the best care, best practice models up front early in their hospitalization.
That's really exciting. That sounds great. I love that proactive approach. Kind of like trying to identify potential issues early, trying to mitigate early rather than having to be reactionary. I think that would be one of my concerns about this model, but it actually sounds like the model may even facilitate that.
It really does, Cyrus. We try to round on every patient at least twice a day, so at least once per shift. And obviously on sicker patients, we may be rounding continuously on those patients in the background. But I don't think we can, and I know Bill will echo this, we can't stress enough how important our team-based approach is. Our nurses, we can't be everywhere at once. So if we have to leave a patient who is in extremis at one point, we'll ask our nurses to assist and help keep an eye on it. And we also have amazing APPs who help us to be more efficient, and they're also expertly trained in critical care and help us provide the best care possible.
One of the things I'll comment on when we talk about the care model, when I was setting all of this stuff up, boy, it's been more than 10 years ago now. Obviously, I very carefully digested the existing literature at the time and leaned heavily on the lessons primarily from the University of Massachusetts, the group led by Craig Lilly. And one of the signals that was very clear at that point and has not been refuted to this day is that in a telecritical care model where the bedside team can opt in or opt out, pick or choose the level of engagement, is associated with a failure of the program to yield meaningful clinical outcomes. And the models in which there is no opt out, the telecritical care team is part of the care team, is associated with accomplishment of meaningful clinical objectives. So we understood that literature at the time, and that's how we built our program. Now, that was a cultural fight because some people were not ready for that. So that's its own story about how we got people to come along, to go along with it.
And that includes the ability not only to proactively round on patients without being asked to, but also to have full order writing capability to intervene when we need to.
Nice.
So there's a lot that I want to unpack there. So yeah, a lot of great stuff. First off, so what's meant by rounds? Like what do rounds consist of?
Yeah, so everybody obviously, just like at the bedside, everybody's rounds probably look a little bit different. But for a typical day, I would say in our program, we're starting off rounding on, 30 to 50 patients on a given day, with our nurse practitioner or PA, as well as we usually have the way our setup is structured. We have multiple docs on different shifts on a given day. But we do a sign out huddle at 7 a.m. where the nurses, pharmacists, APPs, and physicians are all included, and we talk about the sickest patients. Then the providers kind of jump off of that call. The nurses continue a little bit more in-depth checkout on a greater number of patients. And we really focus on our community hospital patients that don't have intensivists at the bedside. So I will, start off, if there are people in extremis, I will generally start off there and make sure that we're looking at those patients early and often and getting our recommendations to the bedside teams as early as possible. And that's really why we've increased our staffing over time, so that we can make sure we're not ending up rounding on sick people at 4 p.m. because that's just obviously not helpful, or much less helpful anyway. And we do not do structured timed rounds with the bedside team. That is a model, but because we are spread out in so many places, and a lot of the telecritical care programs across the country are this way, we just we can't really structure it that way because there's so many things that are pulling us in different directions. But we round at our own pace and in our own order, and we make sure that when we have recommendations, we communicate them to the bedside team directly. So whether that's, luckily getting to run into them when we're on the camera in the patient's room, chatting with the patient and their family or the bedside staff, or making sure we reach out to them via messaging or direct phone call.
Great. And another point I wanted to sort of double click on was, you mentioned that some of these patients are being managed by non-intensivists and others are. Right. So how is that dynamic different when you have people who have an intensivist on the ground versus not?
Yeah. So when we set up our program, looking at across our system, and this originally was just happened inside our system, about 85% of the critical care was being given in facilities with 24/7 in-house critical care, and about 15% was being given by a combination of family physicians, community internists, community surgeons, and in some cases, hospitalists in rural hospitals. Or they were in a rural setting where it just was critical care in an ER as someone would pass through, or in a moving vehicle. That 15 to 20% of the volume was enough to keep us busy, and the care given by our intensivists was already highly standardized and highly protocolized. One of the features of Intermountain as a whole, I would say, is our commitment to highly standardized, highly protocolized care, and critical care has historically been the leader in that area. So when we looked at the workload ahead of us, we made a formal decision to not be involved in the intensivist staffed hospitals, with rare exceptions. Sometimes, one of us will be getting 3 simultaneous unstable admissions, and we might call over to our buddy in Tele-Critical Care and say, "Hey, listen, can you take a look at bed 35? I'm gonna be in bed 32 for the next hour." That kind of thing. So, not that we do have privileges at those hospitals, But as a workload thing, we felt there was more bang for the buck for us to focus. Now, recognize that that model is unique. Again, I mentioned the University of Massachusetts program, which at the time we were setting up was the best studied, best reported on program. And they absolutely are involved when there's a bedside intensivist. For us, it was a practical reality that we didn't have enough bandwidth to do that. And I think in the end, it's worked out well for us to let the intensivist run units run and for us to focus outside of that.
That dovetails really nicely with something I wanted to get to, which is, this idea of, in critical care medicine, there's this weird, I don't know if it's a false dichotomy or a true dichotomy. I guess it depends on how you look at it. But, we're responsible for maintaining oversight of the patient and oversight of the unit and really not missing those important details. It's kind of like the situation where in the ICU, we know that the devil's in the details, but you can't miss the forest for the trees. And so I often find, myself struggling at times, satisfying all of those needs for the patient, for the unit. But as I'm listening to you, Bill and David, to you guys describe this, it almost sounds kind of like akin to a code situation where when you have tele ICU in place, excuse me, when you have telecritical care in place, you're able to truly be at the foot of the bed and watch and see what's going on. Watch those folks intervening and really have oversight without the temptation to jump in, get your hands dirty, and then put the blinders on, which I think is a concern that I have. David, what are your thoughts on that perspective?
I think that's a great observation, Cyrus. I that being remote and not at the bedside certainly gives us an opportunity to achieve global perspective because that's all we can get. We're not there, but it also encourages great teamwork. And that's how, because the details are important, as you mentioned. We strive in our program not to be medical consultants, internal medicine consultants, unless we're specifically asked to do so, because most of the people we're working with are great at that part of the job already. We want to make sure we're there for our critical care expertise and specifically commenting and caring for those ailments that the folks at the bedside don't necessarily feel as comfortable with. So I think it really boils down to the way to meld those together is to just strive for fantastic teamwork and make sure you're communicating in depth with the bedside. Because I can't tell you how many times over the last decade that I've thought something and like, man, this seems a little bit off to me, and then I make a phone call to my bedside colleague and I'll get the clarifying answer there because they just have a little bit different perspective. Like, that's so important. Thank you. Now I understand.
Hmm.
And so it really is all about relationship building and communication.
When I was with you in Seattle that one night, one of the things that really struck me was how you guys have two ICU physicians on at night. Uh, and you can kind of collaborate and work together on challenging cases, or then functionally you can also divide and conquer. And I love how with this telecritical care model, you can kind of do that and then some, all in the best interest of your patients.
Yeah, I think the load leveling is a really important capability, because like one of the things that's really kind of scary about being an intensivist on when you're on alone, especially, is you can only be in one place at once, but often you have to be watching many things at once. And being able to phone a friend and ask your colleague in telecritical care, hey, can you keep the rest of the unit from burning down while I go deal with this problem? That's huge. I wanted to ask, so, I can imagine that there'd be pushback from people who feel like they're being sort of like second guessed or like, who's this person literally looking over my shoulder? How do you guys like diffuse that issue and how do you integrate with the teams on site?
Yeah, so this was a major challenge when we first set all this stuff up, and I literally had to go to every hospital's medical executive committee and have a two-way dialogue with the physician leaders at that hospital because they had to approve this as a service at that hospital. So I had to direct this, or rather, I had to approach this question directly up front. And my message is that, number one, the camera's not on all the time, and we have far more to do than to just sit and stare at what's happening in the room all the time. Number two was to reemphasize the point that the attending physician is the attending physician, and we're a consultant. And all of us had had years of experience. At that time, all of us had a pulmonary and critical care background. So we had years of experience serving as a pulmonary consultant and a critical care attending at different parts of our job. And much of how you successfully work in telecritical care is just following the principles of being a good consultant. And so I had to be able to address that up front. One of the things that I had to reassure people was that we were accountable to them. Part of us having privileges in their hospital, would that be is that our bad behavior, for example, if there were any, would be reflected in our own credentials files. We had skin in the game along with them.
Mm.
And so a lot of this was about, building trust. One of the important communication things that I want to call out here, because I think this was important for our development, and Dave hit on it a little bit. He and I were both trained and experienced as simulation facilitators. And one of the things that was very much a current issue when we were being trained was this concept of debriefing with good judgment, right?
Mm.
Like, you don't want to come across as judgmental, but if you say something, see something, you can't be afraid to call that out. And so one of the mantras we were taught is, I see, I think, I wonder. And it didn't take long in telecritical care to realize that these interactions were very much like debriefing somebody after a simulation. And there was a way that you could express yourself that made a friend and a colleague, and a way that you could express yourself that made somebody really mad at you. And an example that I bring up, one of the rural hospitals we worked at, there was a physician who seemed to love to use carbapenems for what seemed like a routine infection. And the idea being, well, if they're sick, they must need a carbapenem, right? So um, at times it got pretty frustrating to try to help with a little bit of antibiotic stewardship. And maybe it was tempting sometimes to call up and say, like, what's going on here? But the time that you do that, you'll find out that he's got a fax copy of culture results from the patient's internist that are not in the medical record, that they got a culture 2 days ago, and it's a resistant organism, and you really do need meropenem, right? So the idea of I see, I think, I wonder is, instead of just going into attack mode, you approach it with true curiosity and allow them to explain that piece of information they have that you don't have. And if there is no such information, then you've approached this from a collegial aspect and maybe can change their behavior. But if you approach this in attack mode, you're going to get attack mode back again. So does that make sense, that you
Makes
approach
great
this like a
sense.
simulation debriefing, and whatever the outcome is, you've built teamwork with that person?
Another thing I think is important to bring up is this is an iterative process, right? You, we, there's also always blips and snafus as you develop relationships, because there's a lot of high stakes here. People's lives are literally on the line, and everybody wants to do the best for the patient. So we make sure that as a team and as a leadership structure, when there are issues, we address them directly. We address them with the bedside providers, the nurses, the physicians, anybody involved. When we have to go out to if there's big issues, we make sure we make more visits. We go out in person. We go to their staff meetings. We just want to make sure that we're all on the same page and everybody understands. And this kind of goes back to simulation as well. There's something called the basic assumption, that you understand that everybody who's on your team wants the best outcome for the patient. And as long as we can work from that construct, it makes everything a heck of a lot easier.
So yeah, there's a lot there that I think I just want to sort of summarize. So Bill, I know with your background, being a retired colonel in the from the Air Force, the sort of aviation parallels are very they resonate with me too, as someone familiar with the military. And as far as my understanding of civilian aviation as well, there's this importance placed on good communication, closed loop communication. This is sort of like these are all high stakes decisions, or oftentimes these are high stakes decisions that are being made. And I love how you marry the need to be, the need to not skirt those issues with a tactfulness in the sort of I see, I think, I wonder approach to raising these issues. I think that's really, really critical.
And I think it's applicable outside of telecritical care as well, obviously.
Very
like
much
that's just how to be a good consultant and not be a jerk 101.
Yeah.
Yep.
And I think the other go ahead, David.
Oh, it's also helpful in marriage.
Yes.
Yes, very true.
I notice that the forks are not in the fork drawer. I wonder why that might. Yeah.
So the other thing too that the other thing that I wanted to mention is this idea of it being an iterative process, as you said. It's kind of like, it's not a set it and forget it sort of thing. It's like, if there are issues, then you're not just going to kind of hide behind the screen and shrug your shoulders and just kind of deal with it in that sense, but rather getting out there, laying eyes on the situation, interfacing with these folks. I think that that's probably very powerful and allows you to maintain strong working relationships. At least that's what I'm hearing. I don't know.
That's 100% true. It's, culture change, as you guys know, is hard. And everywhere we start a new site, it was a culture change. So we worked really hard, and we over the years have, figured out what works really well for our program and what doesn't work for our program. Because there are practice models that we don't work well in, and we figured that out over time. But when we commit to some place, we really want to form a partnership with those teams. And it is just an ongoing relationship. And just like every relationship, it takes work. Some days are great and some days there are bumps, and you just have to get on the ground and sit down at a table together, literally, and work out the kinks.
Well said. Well said.
And I think that's important too, which is that, that telecritical care doesn't mean you're never in the same place. It just means that you're often not in the same place. And I think that's really valuable too. People that you've met face to face, you have often a better rapport with, more of a relationship with, and it's easy to build on that, in a stressful situation when you're only on a screen.
Two other communication practices that served us well. One was a commitment to never pick a fight in the chart. Again, part of being a good consultant. And I guess I would say the difference, as somebody who's been a consultant for decades before I started this, is the volume we have is much, much higher, right? And the opportunity for conflict. And so you've got to drill down that much more on, if I see myself putting something in there that's going to start a fight or put them in a bad position, I need to take a deep breath and call them and work it out directly. And so that we're not creating a problem in the chart that way. And another communication practice that was very important was to not use the bedside nurse as a message, as a secretary, right? If you've got something to tell the doctor, don't say to the bedside nurse, hey, the next time you see your doc, tell them XYZ. What you need to do is go through the sometimes laborious process of figuring out how to get a hold of that person. And they may be down in the ER doing a floor admission or their 5th floor admission in the hour, but you still got to make the effort to contact them directly. And if it's something important, little things you can leave in the chart, important things, don't use the nurse as a message taker. You got to take the effort to contact them directly.
I think to further Bill's point there, it's important for the chart war, to avoid the chart wars. We also don't ever want to paint our teammates into corners, knowing that other places are resource limited. We can't say you must transfer this patient because, right? We might suggest something, and if we need to be more firm about a recommendation, that is usually done offline in a person-to-person conversation where we can, give a lot of background and context to our firm recommendation.
All great points. Thank you guys for sharing those communication pearls. I want to get a little granular here as we sort of continue our discussion of telecritical care. So maybe Bill, you can let me know. So what is your sort of, either your or an example of a command center, what does that actually look like in terms of the equipment that needs to be there, the personnel? And then David, maybe you can pick up by saying, what do you need as far as the boots on the ground in terms of personnel and, again, equipment?
Yep. So the heart of our clinical command center is a team of senior RNs, generally graduated house supervisors from our trauma centers, and transfer specialists that take incoming call. And they are the primary point of access for a lot of acute services, whether it's telestroke or transferring a patient or neonatology, a number of things outside the system. You go through that command center. And so they've got two-way audio, access to the medical records, great telephony. They can make a call with 15 different people on it. So again, it's a communication center, and they've got great communication into our hospitals, right? And again, part of the point of them having been house supervisors, they know how to get something done. If they hear someone's in the OR, they know how to get to the front desk, to the room, to the circulating nurse, to get a word to the surgeon when they've got a spare second to say, can you take this next person coming in with a head bleed? Or are you still going to be in this case? So it's communication. Most of it is the talent, skill, and knowledge of the people you hire, but then you've got to surround them with good telephony. And then next to that, then you position your other major acute telehealth services, like in our case, adult, pediatric, neonatal, critical care, as well as hospital medicine. So that's the core of a command center.
When we think about our technology, as Bill said, it's really about the personnel and how you operate. And we were very deliberate about the decision not to be one of the most high-tech programs. We did not buy into a lot of the proactive alarm systems, really relying on communication and frequent rounding to overcome some of those things. And we've had great outcomes in spite of not having some of those advanced technology suites. We generally recommend in all of our rooms to have a permanent room kit, which is a very high definition, zoomable and adjustable camera, as well as an in situ microphone that's there all the time. We also operate on carts in different sites because you also always need a backup in case the technology goes down. The carts, we generally like them a little bit less, but for some programs they may be better. For things like Tele-stroke, where you may need a different angle to do a better neuro exam, a cart might actually work better than the more high tech in room kits. We have, as I was talking about earlier, I mentioned we've developed an algorithm for what we like to work, the situations and relationships we like to work in. We always need to have our program operates best when we have someone on the ground to partner with. We are pretty agnostic in general, whether that is a physician or an APP. We operate in both models. In some places, we work with internists who work as hospitalists. Some places it's FP docs. Some places it's nurse practitioners who primarily run different units. But we want somebody there available on the ground who is the primary attending or point of contact for the patient and primarily responsible for everything. And we, again, act as a consultant and want to give as much help or as little help as they need. We also need people available to do procedures. And in different places, that's different things. In some places, that's anesthesia, who's always available on call. Some places, that's ER. Some places, that's local general surgeons who help out with procedural skills.
Great. I think those are really important points. And I love that both of you emphasize the importance of people primarily and technology secondarily, right? Because I think a lot of places that contemplate having critical care are imagining like a tens of millions of dollar price tag and like some NASA-esque room with hundreds of desks and giant monitors, and that's not the reality of what you're describing. What you're describing is committed people who know how to get stuff done, and they can connect patients or providers to the experts they need to talk to.
Yep. Simple, reliable technology. And this is an area that is saturated with vendors who will you're under constant pressure to add all kinds of technology. And again, we were very disciplined pushing back against that. Number one, that made our system simple, robust, and reliable, secure. That's very, very important, right? You're getting signals into a deeply personal environment. We need to be able to assure our patients that nobody else can get a hold of that signal that's not supposed to. So it gives you all those advantages plus expense. One of the things that we have done is partnered with now north of 40 not for profit, community owned hospitals around our region of the country, and we now provide services with them. Now, not critical care for all of them. Critical care is probably in 15, and we've got other services, infectious disease and stroke and others in those other areas. But we couldn't do that if we were junked up with a lot of very expensive technology. I'd make a military analogy. When you're going on a deployment, everyone's got an idea of something that belongs in your rucksack, and you could end up with this massive rucksack that a soldier couldn't stand up can't under the weight of this. In this case, the quote weight in the rucksack would be licensing fees for all this technology. If
Mm.
we allow our program to get junked up with a lot of additional licensing fees, we price ourselves out of these little hospitals that don't need all that. What they just need is a second set of eyes, a second set of ears, someone to think through. So again, we're very strongly believe in a simple, robust solution here.
And it's so important because that's really where, that's where I find the most joy in this job is working with those tiny little teams who are so poorly resourced, but are so very connected to their patients. I can't tell you when I was specifically the medical director for the Tele-Critical Care Service, how many not fights, but discussions I would get into with local leaders about, doing things differently. But it was always a discussion I was willing to have because I knew exactly where they were coming from. This was their neighbor from down the street, and they were so invested in what happens. They wanted to make sure that I was as invested in that patient's care as they are.
Great summary of what it takes to be and to establish one of these telecritical care programs. What are some misconceptions regarding telecritical care?
And I think the biggest misconception, Nick, resides around we're always watching, we're big brother, we're here to take over. Especially when you're a big presence in the region or field, even like Intermountain is, we see that a lot, or at least saw that a lot when we're establishing programs or at least getting started up. But we stress very highly that we really just want to collaborate with the bedside teams. We want to help them take the best care of their patients, and we don't want to take their jobs or anything of that nature. I don't know of any, again, we don't really operate in facilities that have intensivists at the bedside, at least as a part of our main operating model. So we're not there to take away people's critical care jobs or anything of that nature. There's nowhere near enough of us to go around. So we just are trying to get the best critical care to the most people possible.
Yeah, I think that's a really important point to clarify for people, which is that this is a value add. This is not like, IT jobs getting sent to overseas. This is you have more support in your hospital by experts who are familiar with your hospital and help you take care of the patients that maybe you know better.
Yep. One of the misperceptions that I've run into with some folks is that by now having responsibility for a much larger list of patients and sharing that responsibility with people who are far less trained, that it puts them at risk of being sued for a bad outcome. And it's very hard to find direct literature on this, but certainly the available signal from the available literature is that, in fact, the chance of having a bad outcome resulting in in a lawsuit is substantially reduced. One of the things that we set up in our program, because we don't bill directly for our services, we work on a subscription model. We don't have to write billable notes. A consequence of that is that we don't have these long, rambling behemoth notes like we have to write when we're bedside attending. We just have to have small notes that justify our judgment. And I think that makes it a lot easier for us to be able to just hit the information that went into our judgment, why we made that recommendation or write the order that we wrote, whatever it is. I think that provides a substantial protection, right? And somebody looking through the chart will be able to see that person in a small hospital got help from someone in a big hospital. The person in the big hospital can, in a very short note, document what their thought process was and why that path was taken. So that's a misperception that I would address. This is not an invitation, an open invitation from the trial lawyers to go after you.
Great. Yeah, I think that model is really important to emphasize too, which is that, that multiple sets of eyes reduce the likelihood of errors happening, and more likely to catch errors sooner, more likely to adopt best practices. Like, I mean, it's good for everybody essentially. One thing that I noticed a lot, especially at like the height of the pandemic, when we were getting transfer calls from several states to sort of move patients to tertiary centers, and often we didn't have beds, but just having the conversation sometimes with like the person in a small hospital, um, in some cases, they're almost asking as much for a consultation as they are asking for a specific service that they don't offer. I'm curious, David and Bill, both of you, since setting up your program, have you noticed that the rates of transfer have changed, that there's more people who are able to receive high quality care without changing hospitals?
Absolutely. That was an explicit aim of our program from the get-go, by the way, was to reduce the number of unnecessary transports. And we've measured this in the adult and in the the neonatal age ranges. Our pediatric program is not mature enough and maybe never will be because of pediatric ICU distribution. But for adults
I
and
have to say,
neonates,
so your neonatal program is mature enough.
Well, there are more neonatal ICUs across the state, across
yeah,
our region than there are pediatric ICUs. Many more.
pediatric ICUs, right?
Sorry,
So
I couldn't
I'm
resist the joke there.
play
Sorry,
on
guys.
words, right? And if I was really clever, I would be able to riff on that with surfactants somehow, but I'm not that clever. So the fact is that the distribution of nurseries, whether different levels of NICU and adult ICUs, is such that we've been able to measure a clear decrement in the need to transfer patients. And what we believe, and this is very hard to measure, but certainly we and many others believe that people will heal better if they're close to home, close to their loved ones. And it's certainly less expensive to give care in those hospitals. So if we can assure them of high quality care and comparable outcomes for the disease that they have, they would rather stay close to home. And there's an economic benefit to that.
And
So
and I would imagine the opportunity cost is significant too,
yes.
right? That your highly skilled critical care transport people can only be in so many places at once. So prioritizing the transports that really need to happen is good for them and good for those patients who need to move.
And that
That's
humanistic
absolutely
benefit,
right.
that humanistic benefit that you mentioned too, is keeping folks closer to home is like
Well,
a
Huge.
huge
so
deal.
along that same vein, we have some early unpublished data that shows that early on in our program implementations, we still transferred out the sickest patients, but we transferred them out earlier, which is probably
Hmm.
better for them. If we can, if you're a skilled and veteran critical care provider, you kind of have a good gestalt of where people are going to go. So you can get those people who are going to need highest levels of services out of poorly resourced places as quickly as possible. But we still increased our overall um, severity of illness levels while improving mortality in situ in our small hospitals,
Hmm.
which is exactly kind of the goal that Bill was going towards when he started the program.
Yep. And by the way, this preserves capacity at our most advanced centers, right? So one of the light bulb went off for me early on when we were keeping people in the community hospitals is that we now kept um, beds open at the advanced centers. And then when we got into the pandemic and we started working with hospitals outside of our system, it occurred to me that part of our capacity plan was keeping sick, complex patients in these non intermountain hospitals when that was the right thing for them, right? We're not, this is not a rationing of care decision. This is a careful discussion involving patients if they're conscious, their family members, the bedside care team, that if we can provide great care and great outcomes close to home, not only do they benefit, but by the way, that next person that comes in that doesn't have a choice benefits. And probably a few months ago, there was a night like that at a rural critical access hospital. Someone came in that septic shock, respiratory failure, but it looked like they might get off the ventilator in a day, low dose of vasopressors. We had a careful discussion and chose to keep that person there. Our quaternary center had one bed left in the ICU. I kid you not, that same hospital had someone come in fulminant hepatic failure about an hour and a half later, and there was no question. Now we had a bed. Instead of having somebody with a quarter's worth of sepsis and respiratory failure in that bed, that person was getting good care close to home. The person with fulminant hepatic failure went straight to the transplant center. So that's an example of how this thing kind of plays out, thinking as a system, right? This is now we're functioning as a system across a very broad geographic area.
Yeah, I can imagine there's significant economies of scale and efficiencies that go along with that when you start to have the ability to really move people where they can get what they need and free up space where space is needed. Very exciting.
One of the causes of an unnecessary transfer, by the way, and we've all seen this in our career, that person that gets off the helicopter and within 10 minutes that there's nothing that can be done for them, right?
Mm.
And what I say is the folklore of that family for the next 15 years will be the night that grandma died alone in the big city while people were scrambling for childcare and pet care, livestock care, and driving in and out of in and out of cell coverage through mountain passes to be there. And it's a very different story and this conversation has to be approached in a very careful way. But when you recognize that there's nothing that can be done, and the bedside team introduces the discussion, and then we come in as the big city doctors to emphasize that the family members almost always knew that that was the answer all along. And it's like they had permission to not do a transfer. And you could see the whole room change. Now they know that grandma or grandpa or whoever it was not going to make it. But now instead of being this stressed out, desperate, clinging for an outcome that won't happen, now people are crowded around the bedside holding hands and people from church, neighbors, and the whole 9 yards. So that is a form of unnecessary transport that we avoid. Again, a substantial financial benefit, and of course, the human benefit for that. So by knocking down the people who were not sick enough and can be cared for well, the people who were moribund and were not going to benefit, then we focus those resources on that population that really can that will get a better outcome because of our resources.
So you guys have really highlighted some very exciting elements of telecritical care and all it has to offer. Maybe we can take a moment to hit some of the pitfalls and pearls in particular that you guys have identified as it relates to telecritical care. I think we touched on in pre-recording licensing issues and the many EHRs that you might have to deal with is kind of like some of the potential pitfalls. But yeah, what are some of the major elements that you guys have taken away from your time in this career field?
I'll mention the licensing and credentialing thing first. Having come out of hospital operations in my background, right, where we had to think about our infrastructure costs included, paving the parking lot and the air handler unit and all that other stuff. One of the things that we as a virtual hospital just had to take on and move past it was the cost of licensing. And so our team, our virtual hospital licensing team, manages thousands of licenses. The ladies, and there happen to be women that run this, have credit card bills every month that are on the order of $20,000 or $30,000 each because of that. And we just had to say that's part of the infrastructure of doing this work. We're not going to balk at it. We're just going to take that on. And by doing that and rolling that into the cost of our services, it's allowed us to expand greatly. And so, in the end, a low cost. Part of the economics here, and I want to take a second to point this out. In rural hospitals, critical access hospitals are in crisis in America, and they're closing down at a shocking rate. When a hospital closes, health outcomes for a substantial radius are measurably worsened by that. When we can keep one or two more patients in their average daily census there present, and the income from that care, the bed days, the pharmacy, the lab, the imaging stays in that community, then everybody in that community benefits from a robust system, and we don't, and that pays for our licensing and all that other stuff. So the biggest thing I'd say is don't balk at that. Don't try to be cheap. If you're going to go down this road, that's part of the cost of doing business. Just build it into your operation and move on.
I'm curious as a follow-up to that. I think that's a fantastic point, by the way, that like if you're gonna do this, do it right, get people the licenses in all the states they need so they can practice wherever they need to. What about time though? Because in some cases that's a more scarce resource. And I'm just imagining having to do a HIPAA module at 20 hospitals. So that just sounds like I'd want to end my life.
So that's a great point, Nick. We do credentialing by proxy.
Mm.
And we've tried it other ways and it doesn't work because you're right. It's hard, as you might imagine, it's difficult to convince a large group of busy physicians to do all their compliance modules at their home hospitals, as well as I'm trying to think. We currently practice in 30-ish hospitals.
Yeah.
So that, I think but we're in 16 or 17 outside of Intermountain. So it'd be like, another 17 worth. But we do credentialing by proxy for specifically that reason.
Mm.
If you have a clean package, you're a good citizen in your own group. Those characteristics are applied to your application at our partner hospitals.
That seems like a very efficient way to do it, all things considered, and it allows you to have that uh, that kind of reach that you want and you need without all the headaches that Nick was alluding to.
And then also, again, these critical access hospitals are also poorly resourced in in many non-clinical aspects too. They don't have a giant credentialing team either. So if we can do a lot of that upfront vetting for them, it actually saves them work in the end.
That's a really good point.
Um,
So I want
go
to
ahead.
talk about kind of who's on your team, like who goes into this specialty. Are these people who are splitting their time between a brick and mortar ICU and a tele-critical care practice, or are these people who are doing mostly one or mostly one?
Yes. So I don't know if Bill, this is Bill's grand plan, but I'll speak to some of it. I've been around since the beginning. Our initial model, particularly at Intermountain, and I can't speak for everywhere in the world. I know there's lots of different models. There are plenty of places that are only tele, but we initially strove to only have people who worked at the bedside as well as doing tele, and with various splits of time between the two. I want to say I was about 50-50 or 60-40, one of the bedside to tele when I started back with Intermountain a decade ago. Over time, we've learned that to keep up with the market and to make sure we're getting adequate providers to sustain our growth and good providers to sustain our growth, we had to change our model a little bit. So we initially opened it up to what we'll call seasoned providers or seasoned physicians and APPs who are, later in their career and had, put 20 plus years in and want to sunset a little bit, and this is a great way for them to have a little bit more comfortable schedule, and kind of, slowly get out of their careers in a way that makes them feel loved and, cared for. But we also do have new providers who are earlier in their careers who are doing tele only, and some of that's a lifestyle choice. Young families to take care of. This allows them a little more portability. So yeah, we have the entire spectrum now.
Do you guys in particular worry about degradation of your actual clinical bedside skills when so much of your time is involved in tele ICU, or sorry, when so much of your time is involved in telecritical care, or have you found ways to sort of mitigate that, and now 10 years down the road?
Yeah, I mean, most of us still split our time. I think the
Okay.
people who are tele only in our group are almost entirely at the end of their career. After 35 years as a bedside intensivist, they're not going to go back to that again.
I
Their
see.
cognitive abilities are probably at or near the strongest it's ever been. And so that's not a problem. For the rest of us, we split our time. And, if I'm starting to worry that maybe I haven't done enough intubations this year, then I go to the OR and one of the anesthesia guys can walk me through some extra intubations, right? If I haven't done enough central lines, we've got central line mannequins or whatever. So it does take some attention, but I would say that's more of a hospital challenge.
Mm.
And reflecting on some of the full-time faculty at academic medical centers, probably we spend as much time at the bedside as some of the faculty folks do. So it I'm not glossing over this. It's a real issue and it deserves attention. But I would say that we've been managing it for the couple of younger folks who are more in this mode. Then when they want to transition back, there's going to have to be some time where they pick up on that. Most of the skills, it's still primarily a cognitive-based specialty, and I I don't always come home from a busy day as bedside attending thinking, "I learned something new today." Right? I've been doing this a long time, but when I come home from a day of telecritical care, it's unusual that I don't think, "Hey, I learned something new today," just because of the sheer volume. And so for our ability to collect and interpret history, an observation of the patient and the scene in the room, and then put it all together, this exercises that core chunk of what it takes to be an ICU doc extraordinarily well, better, I think, than our time at the bedside. And the other stuff, putting in central lines, chest tubes, intubations, that kind of stuff, if it takes a little extra effort and you've got your buddy to look over your shoulder when you're bedside attending, then just do it.
It's
I
awesome.
think that's a great point, that this is primarily a cognitive specialty, and flexing those cognitive muscles by seeing a larger volume of patients doesn't, yeah, if anything, it makes you a stronger bedside clinician.
It's awesome. Hey, so
Amen.
you mentioned, Bill, this idea of like the delta between, um, you know, how involved or how engaged you guys are versus some of these faculty intensivists that maybe have a bunch of different hats to wear as well, and they may be getting pulled in many different directions. So, kind of to riff off of that, do you guys interact with trainees at all, and how does that work?
I would say that it's disappointing actually how little of that we have done considering the opportunity. We've had some fellows come spend some time with us. So our program is very closely tied to the University of Utah, and we have medical students, residents, and fellows that are with us at the bedside. And a surprisingly small number of them have taken advantage of this opportunity, but when they do, it works great, right? Because again, they get to pick and choose from a very, very high case volume, and they can drill down onto some interesting or exotic things they might not see otherwise. So I think this is set up beautifully for fellows, despite or any trainee at any level, despite the fact that we have an abundance of them in our community that we work with in the hospital. We haven't done as much with that as we should.
Yeah, I think what you have to tell them, I remember when I was in med school, there was this sort of legend of this ER doc who lived like most of the year in Barcelona and then like came back to New York to do like a couple of shifts. And like, just tell the fellows that they'll get to live these like crazy jet setter lives like that. Thinking about kind of the future of the specialty, the future of telecritical care, um, we're sort of in the midst of an obvious AI revolution right now. How do you see that influencing how telecritical care medicine is practiced in the future?
Good. I can address that. Certainly, AI comes in many, many forms. One of the forms that's probably a little more developed is this ambient listening. And I can tell you in our system, and I'm certain in your systems as well, it's been well developed in clinics that you turn this on and you have a conversation with a patient, and instead of looking at the computer, you're looking at them, and the system documents for you in an appropriate way. So we are working now with the nursing version of that program where a system listens to interactions between a remote nurse and a bedside nurse and then documents on behalf of the bedside nurse. And the the place where this has been the most well developed, the system that we're using at Northwestern University saw a dramatic decrease in nursing overtime. And this was not overtime that the nurses wanted, by the way. They were not saying, oh, please, please let me stay after for an hour and a half and get overtime pay to do catch up charting. They were more than happy to not have that overtime and go home and
They,
be
they
with
had
their
an they
family.
had an exhausting shift, which is why they didn't do the charting.
They
They just
didn't
want to
do
go
the
home and go to
charting,
sleep. Yeah.
exactly, yep. So, that's an early example of AI that we're actually working with right now, and again, it doesn't have to be based out of a telecritical care center, but because we sort of own the cameras, own the signal, we have the technology folks, it makes most sense for us to oversee the rollout and deployment of that. So that's a simple practical use of AI. It's computer vision machine learning and computer hearing machine learning, right? So these audio visual systems are watching and listening to interactions, learning from this, right? You're training a deep learning neural network algorithm and then closing the loop to document that in the electronic medical record. So that's a very simple, practical, early use of AI in television.
And I think one point to emphasize about that that's really key is that's not LLMs taking people's jobs. That's LLMs making people's jobs better by removing some of the less fun aspects of their job.
Yeah,
Yep.
I can imagine that's true. And I think as I'm thinking through this, I imagine, one of the challenges at times as your network grows is triaging. And so I can see a world where, yes, you have, I know, many different team members that are helping with that, but wouldn't it be nice if you had sort of a robust AI assistant that could also help in triaging and identifying sort of like, and we're already seeing this to a certain extent, but like, those early warning indicators, just having that as an additional layer of filter to make sure that you guys are going through things in the most efficient and effective order when you're sorting through your dozens and dozens of patients.
Yep, absolutely. That's something that has been on our wish list for many years. We don't have access to the right kind of AI programmers to make that a reality. An area that we are actively working in, though, and this has been my research focus for many years now, is in patient safety. And so my team has had a longstanding collaboration with what's called the Stanford PAC team, or the Program in AI Assisted Care. So it's clinical people from Stanford Medicine and AI people from Stanford University working in our intensive care unit to train these systems to recognize events that are pertinent to patient safety. And we have a publication regarding hand hygiene and tracking actually how much of that is done, and we're continuing that work. And one of the forms of preventable harm in critical care, the post-ICU syndrome, is tied to immobility. And so we have a publication in Nature Digital Medicine showing that we could train these systems to monitor physical therapy, how much of it was done, how much help it took. And the point of being able to document that in an ambient way in the background is it makes it a lot easier to focus resources on patients that are not getting that done. And there's a whole other host of preventable harms in critical care that we're taking on. So we do, in this case, because of our collaboration with Stanford, have the right access to the right computer programmers to make that a reality. And we are continuing down that road.
Exciting stuff.
Indeed. It's great applications currently in play and then on the horizon, I think. As our time sort of winds down, so far has been really a great discussion on some content that I've learned a lot from. So thank you guys for that. I think we'd be remiss not to discuss maybe the unique medical legal elements as it relates to telecritical care. We talked a little bit about licensing and how that can be a challenge. But for example, if you guys are in the heat of the moment making recommendations and those either are not or cannot be acted upon, where does that leave you in terms of liability? Is that a concern? And then another sort of related question is just, I think you alluded to this. I think you alluded to this as well. But how do you guys actually get paid? It sounds like you guys aren't getting reimbursed for procedures and things like that. So surely this has to be sustainable, right?
Absolutely. What's the old adage? No margin, no mission, right?
Yeah.
And we certainly live and die by that. We talked a little bit about the licensure earlier, and how we try to make it easier after the licensure. We have a fantastic licensing team that does pretty much all the hard work. And when we're onboarding new providers, I say just do what the licensing team tells you, and your life will be better. They are the experts, so just follow their lead. So the credentialing by proxy really helps that. Intermountain, and Bill, when he was setting this program up, really made a conscious effort that we didn't want to be writing notes and billing per patient for this express reason. We wanted to use our time and our resources smarter than that. So if there's a GI bleed waiting for a scope who's just in the ICU waiting for their scope, I don't really need to write a note to tell the internist to put the patient on a PPI when they're already on a PPI, when they have an intubated patient on 2 pressors, 2 beds down, so I can spend my time taking care of that patient and offering real advice that might be useful. So we offer our program via subscription service. It's based on an average daily census. So looking at the census over time prior to our implementation, and then we do it on our contracts are adjustable every 6 months based on the usage. So we don't want to overcharge or undercharge. If they're not getting the volume they expected when they signed up with us, we want to make sure we're not overcharging these small hospitals. We're not there to leech money off of them. As we said, our goal is to help them be sustainable. And I'll say that we work with many critical access hospitals, and there hasn't been one that's associated with us that's had to close because of financial reasons in the decade we've been in operation, which I think is a testament to the way that we are able to help them maintain their censuses and keep people in their community locally.
And are you guys limited to hospitals in the state of Utah or nationwide?
We're in 9 states presently.
Cool. Nice.
And we really do focus mainly on the Intermountain West. And there's enough room for expansion and over time here that we haven't really delved outside of that, but that's not off the table down the road. And you also asked a question about what happens when our recommendations can't be carried out.
Yeah. So like if you guys are saying, we need to do X, Y, and Z with this patient, for whatever reason, there's a delay or that doesn't happen the way it should. There's a procedural complication. I don't know.
There's a hospital that can't offer dialysis. They just physically don't have it, for example.
Yeah. So, we offer assistance with transportation in that case. We know that we have facilities that can offer that. And in those situations, we try to assist, if it's the right thing for that patient, to move them to one of the hospitals in our system or out of our system. One of the other things that we stress when we start up programs is while we, if you want to send patients to us, we're very happy for you to do so. However, if your natural referral pattern doesn't filter into one of our hospitals, that's okay too. We don't want to change that. We want to make sure that your patients are staying in the communities where they're most comfortable. And if you're getting great care with your current system, we want to help you keep the patients you can in your own hospital and help you make the decision when your resources are no longer adequate to get them to the right place, whether that's us or someone else.
Yep, and the same goes for transport, by the way, right? We have a substantial program. We operate over 50 aircraft, mainly helicopters, but also a fixed wing and jets. We've got probably another 18 ground ambulances, and there's no pressure from us to use our service. Whatever service they want to use to whatever destination, we're completely supportive of that. And in one of the things that comes up, which again, I think probably helps the overall risk to the patient, there are certainly in our geography, there's plenty of time where weather prohibits any kind of transport, whether it's a blizzard, you can't even drive or anything like that. The fact that we have now consultants who have notes and orders in the chart that reflect we want to do a transport, but it's not physically possible or safe to do a transport, but we're optimizing that patient's care in in advance of the time that the transport can happen. That's pretty hard to argue that you're not making care better there. If there's a bad outcome, it occurred despite everything that we were doing, not because of everything we're doing. So our team is very tuned to that.
Hmm.
And do you guys have like some sort of malpractice coverage for telecritical care?
It's no different from so we are employed by Intermountain Health. Intermountain Health is self-insured, so we have a fund. So the same fund that protects us when we're bedside attendings, when we're in clinic. And by the way, if we're also volunteering at a sanctioned nonprofit event or something like that, we also have that same malpractice. That's what it
Nice.
is. They didn't our underwriters for our program looked at the risk of telehealth and said that this was something that would overall reduce the risk, not
It's awesome.
increase the risk by creating a team. And so there's no concerns. That's never been a problem that we can't continue to grow and expand over concerns of, legal exposure.
One other thing, Bill, that you had mentioned in kind of a timeout that we had was this Tower of Babel effect and how that might relate to some of these unique considerations with telecritical care. Could you elaborate on that?
Yeah, that is, I would say, the biggest thorn in our sides is that we use the EHR of the hospital, and they're different EHRs, and in many ways, it's like speaking a different language. That's why I call it the Tower of Babel effect, because we're speaking the language of Epic versus Cerner versus Meditech. And that constant frame shifting, number one, just keeping track of the logins is a major challenge, right? And then having to frame shift about where do I find this in that chart? Where do I find this in that chart? Um, this, we are more acutely aware of the same national challenge that we all have, which is the fact that electronic medical records don't talk to one another. And I have no insight. for a time, we had a research collaboration with a very large, extremely well-funded technology company, not medical, but they said, "Our programmers are so smart, we can make a new EHR that's better than anything." And I would say that they did make a new EHR that's better than anything, but there may be some privacy concerns surrounding that, which are so strong that in the end, nobody wanted them involved with touching patients' private data. So here we sit, stuck in this, and I don't know a good solution. We've looked at every kind of vendor. This is an area where I'd happy to spend the vendor dollars if somebody had a way, a collector that would put all this stuff together. To our knowledge, it doesn't exist yet.
Yeah, I know from my time in the med tech space that that goal is written on the tombstone of many a startup. I mean, it's
Yeah.
just, as you said, because of HIPAA, because of technological challenges, and because like it's really just not in the interests of the companies that make EHRs to make them truly interoperable. There just isn't a solution to that, and it doesn't seem like there's one on the horizon either.
And this is probably the biggest dissatisfier of physicians who do telecritical care in many different systems. If you're only in your own, covering, if you're at UMass and only covering UMass hospitals, it's probably not as big of a deal. But for for telecritical care programs that go out to other systems, it is a dissatisfier, and we have to be very proactive about how we onboard our folks and make sure that they're aware of this coming into it. And I don't think we've lost anybody because of this, but it's always a point of contention. And again, I long for some better solution down the road as well.
Um, I guess, maybe this is an opportunity for you guys to talk about kind of the things that make your program special. I think you guys have mentioned a lot of things along the way, but what can you tell us about telecritical care that's unique at Intermountain?
I would say the most relevant thing from my perspective is the degree of integration. It allows us to function as a system. Remember, I mentioned that, um, with all the, combat casualties that we were seeing coming from half a world away, that we managed to, using guidelines and communication and rapid transport, to function as if we were one medical staff. Our global program, our telehealth program, exists as part of a virtual hospital, and I would put quotes around that because it's not literally a hospital, it's not licensed as a hospital. But that collection of capabilities allows us to function as a system and keep the right people local and move the right people and make sure there's a bed for them and a way to get them where they need to be. And so I would say that's an essential element, is the fact that we've so tightly tied our patient placement, transfer, acute telehealth services, transport, and our outreach programs all together to serve the community in as seamless a way as possible. That's what I think is our most unique feature.
Yeah, I think that for me, and I think I mentioned it earlier, is really about access to care. We focus a lot of our outreach on small, poorly resourced hospitals where we think we can have the most impact. And I think the success of our program resides a lot from that. Um, we keeping people local in their home communities to be cared for by the people who are important to them, and to have those people around just makes such a huge difference. So the part that we play in that, I think, is one of the most special parts of my job, even if it means that Intermountain's not collecting those patients and bringing them to into our main centers. It's still the right thing to do, and the support we've gotten from high up leadership in the organization to continue that mission has been crucial to the success of our program.
Thank you guys for sharing that. I think what you guys are doing is really exciting. It is eye-opening to me, again, as someone who's certainly not as familiar as with telecritical care as you guys, who are sort of leading the charge, it seems, in a lot of ways. as we close out our conversation, Bill, I'll ask you, and then David next, kind of anything in particular you want to plug, whether it be related to telecritical care or kind of just the practice of critical care medicine in general, something for our listeners to look into in their off time.
I'll go first to give David the last word. I have become very passionate about having people who are critically ill awake, participating in their care, writing longhand messages, getting up and walking around. The ICU that I work at, being on 2 vasopressors and high ventilator settings is no excuse to lay around in bed. You're gonna walk 3 times a day, and at night, you're gonna walk to the shower with the ventilator out of the stream of water, obviously, and then walk back to bed again. And one of the things I love about telecritical care is being able to help people figure out how to operationalize that by staying on camera with them and going through that process of having family members and ICU staff support the patient through those anxious few minutes when the sedation wears off and they wake up again. I am aware that the outcome data on this is not 100% behind this practice, and I would liken this to where we were with prone ventilation, right? It took us a long time working with prone ventilation before we figured out exactly how to do it in a way that improves more, not doesn't just improve physiology, it improves mortality. And I love that part of my practice as a bedside physician. I love bringing that into telecritical care with due respect for the notion that there, we don't yet have a razor sharp knowledge of when to use it and when not to use it. So that's something that I love in critical care.
I want to hear David's answer, but I want to just jump in and just like amplify what you just said, because I agree so much that early mobility is so important. And I think a lot of people who work at smaller hospitals, see like videos on social media of patients on ventilators walking, and their reaction is like, "Oh, that's great. You must have like this giant staff of people to do it."
Or that person is ready for intubation. Why are they
doing
all this?
Yeah, exactly.
Excuse me. Yeah.
And I think that, it's great that you're able to proselytize mobility and make people feel comfortable at smaller hospitals with it, because it's really something that you get comfortable with volume. The first time you ambulate an ECMO patient, you feel very uncomfortable. And by the time you've done it a few times, you're like, okay, we know how to do this safely. And so being able to bring that experience to a small hospital and make them feel comfortable, I think that's a fantastic use. Sorry, I cut you off there, David.
Oh no, I was just waiting patiently. So I think from my standpoint, we talked a little bit about a global perspective from a patient standpoint, but from a system standpoint, the way our program is set up, it really gives you a global perspective on what's going on across a broad geography and across all of our hospitals and all of our partner hospitals. We were able to notice trends, particularly, one example is E-Valley early on. And we were, as a system, because we were, people were, cases were trickling in at one at a time, but we were able to see over 20 hospitals cases trickling in. So it wasn't just trickling in. Like, wow, all these CT scans look the same. What is going on here? And we're able to really, I think, pick up on that early and intervene early, as well as, find some nice publication data to do research with.
Yeah, I think that's a great point. And I think that, thinking about, the next pandemic or the next public health issue, having that sort of like fingers, on many different health systems to spot those trends earlier is very valuable, undoubtedly.
All right, folks. Well, thank you guys for joining us for this really great discussion with Bill and David about the fascinating field of telecritical care. I know Nick and I learned a ton. This is a very important topic. It's clearly a field that's only going to grow, and yet it is rarely covered in the world of critical care. So if you want to learn more, please check out our show notes on the website, www.criticalcaretime.com. I know that these fine folks authored a book chapter, which we'll link to that publication if you guys are interested in taking a gander. While you're on our website, please make sure to subscribe to our mailing list or leave a comment. We plan to kick off our newsletter in the coming months, so stay tuned.
And with that, we come to the part of our show where we like to say thanks. Thanks, first of all, to our guests for joining us today, teaching us so much. Thanks to all the people who left us reviews, especially 5-star reviews on social or shout outs on social media. We really appreciate everything that your suggestions. You give us great fodder for future episodes. And we'd love to keep hearing from you. So you can tweet or X at us at Crit Care Time, or individually at Nick M. Mark or at Askins Razor. You can also follow us on Threads, Instagram, and check out our YouTube channel.
We'd also like to say a big thanks to our sponsor, C-Star Medical. We're fortunate and grateful that this episode and all episodes in Season 2 of Critical Care Time are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
And before we go, we want to say thanks to all the members of our team who made this possible. Certainly the production team over at Podpaste, the people who have helped put the episodes together. Also Kurt Belknap for our theme music, which you're hearing over us right now. This takes a village, and we're lucky to have all the people contributing to this. Now I guess it's time for some disclaimers. Cyrus, you want to hit those?
The views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only. It should not be used in lieu of seeking medical advice. With that, thanks again for listening. I'm Dr. Cyrus Askin.
And I'm Dr. Nick Mark. See you next time.